Hello, welcome to HFMA Talk, the podcast for NHS Finance. I'm Sarah Day, Policy and Research Manager at the HFMA. As services begin to resume in the NHS, we catch up with Sanjay Agrawal to talk about what the ever-present threat of Covid-19 means for working practices and the changes that patients will experience when they visit a hospital. Sanjay is a consultant in respiratory medicine and intensive care at University Hospitals of Leicester NHS Trust and an HFMA trustee. Hi Sanjay, thank you for joining us once again.
Nice to speak to you again, Sarah.
So can you start by giving us an update on what's happening for you?
Yes, so with my intensive care work, I would say we have now reached a steady state of patients whereby there's no further drop-off because we're still getting admissions from around the country for our ECMO service in intensive care, and we're getting the odd patient being admitted with COVID from our wards. But it seems to be fairly steady at the moment. So that's the COVID work. But the good news is we've been able to start up a limited service in terms of our normal surgical services, so cardiac surgery, thoracic surgeries. And we've also noticed that we're starting to get other emergencies back. So people who unfortunately have had cardiac arrest in the community who are brought in as emergencies, we're starting to see that group again. Whereas during COVID, interestingly, there was not so many patients who seemed to be presenting that way. And I think that was reported nationally as well during the peak of the COVID surge. So I would say that there is some return of normality, although we're still spread out in a bigger footprint than we would normally be. And the biggest sort of issue, if you like, is having different bays. So we need a bay for people who are definitely COVID negative, who may have been screened, let's say, for elective surgery. We need a separate bay for people who we're not sure of their status, their COVID status, because there's a turnaround time of around 48 hours to get results back. So we have to treat them as COVID positive, or at least not allow them to mix with COVID negative patients. And then we have our, if you like, COVID positive patients who are in bays. So these three groups we have to not mix. And so that's the sort of biggest logistic issue that we're having to manage going forward. And I would say this is the same issue that every single hospital around the country is going to be doing, whether it's inpatient services or outpatient services. We're all going to have to divide our physical spaces into positives, negatives, and indeterminates in terms of COVID status. And that's probably going to be for the foreseeable future. The other challenge, certainly with our outpatient services, is social distancing. So in past, probably everybody who has listened to this has ever attended a hospital outpatient clinic or even your GP surgery. You'll know that in waiting rooms, people are sat next to each other, which would break all the social distancing rules that we have. So we've had to think about how do we manage that in the outpatient setting, for instance. So we're going to have to limit the number of patients who can ever attend for outpatient face-to-face appointments because of the limited waiting area. So even if we wanted to go back to our previous way of operating, we can't with social distancing. Rightly so, because we don't want to have a hospital transmission of disease. So I think that's going to be for the foreseeable future until large swathes of the population have either had vaccines or are immune. So again, this is something that all hospitals have to do. The other impact that I've noticed social distancing has made is within the working environment. So many of our HFMA members will perhaps be experiencing the same thing, whereby, there might have been a few people crammed into a small office. Now we can't do that, and we need to make sure that people are spread out. So for instance, in my respiratory department, all the secretaries and the clinic coordinators and the other offices, the managerial team, everybody's needed to spread out And of course, the NHS isn't known for its massive estate and ability to have lots of office space. So that's created some logistic problems, notwithstanding the fact that, of course, people are now working from home more, which is helpful. But nonetheless, we seem to have to find space now to allow adequate social distancing. So I would say since I last spoke with you, they're the sort of big things that have come into play. Social distancing, how we do that in our with colleagues, how we do that for our patients in waiting areas, and then of course the issue about physical space and COVID status.
So what process are you going through for elective patients in terms of testing them beforehand? How does that work?
So with the cardiac surgical patients, they're all screened before they have surgery. So that's pretty straightforward. For our bronchoscopy patients, again, they're all screened before they have their outpatient procedures. So I think where it's truly elective, patients are screened before they are listed and appointments made and they have surgery. The difficulty is, of course, some people will need urgent surgery. So somebody, for instance, with an aneurysm repair or an urgent coronary artery bypass graft due to angina or having had a heart attack. And so in those cases, of course, you can't screen. And so you have to get on with the surgery and assume they're COVID positive until proven otherwise.
And it's only been a couple of weeks, but have you noticed any impact from the lockdown easing yet?
So that's a good question. And I would say that we're potentially bracing ourselves, meaning that we know that the way this disease works is that you have a period of 5 or 6 days where people pick up the virus from somebody else. They're asymptomatic. They then develop symptoms, and on about day 10, they come to hospital. So, with that calculation in mind, with the easing up of lockdown and people going to work, I would expect that if there was going to be a second peak, it'll be about a month from the first easing of the lockdown measures. So I'm guessing mid-June. So for me and my colleagues, we're pretty flexible, although we've reduced our intensity of work based on the reduction in the peak numbers. We're very much wary of the fact that we might have to ramp up again in mid-June, which is when we would probably see a second peak in hospital and in the intensive care unit arena. So we've kind of got that in mind. So with introducing new services, reintroducing surgical services, we're aware that we're going to need to keep it at a sort of trickle rather than at full tilt. Because of the potential of a new peak, and also all the other things I just outlined, like physical space and cohorting patients.
Yeah. I saw something on Twitter the other day, which was along the lines of, just because you're bored doesn't mean the virus has gone away. And I'm wondering if you've seen any change in attitudes towards the virus and the people that you're seeing.
I would say probably, yeah, that there's a real risk of us becoming complacent, and it can be around people's behaviours, for instance, wearing masks or meeting up with other people, friends, colleagues, family. It could be also around things like hand washing, or the way in which they wear personal protective equipment. So there is a real risk about complacency. The virus hasn't gone away, but human behaviour is such that you can only focus and concentrate often for a relatively short amount of time. And there is a risk that we're going to make things worse by becoming complacent.
Just changing topic a little bit, we've talked in the past about the wellbeing preparation that has gone into supporting staff in the hospital. Now that things are evening out a little bit and the immediate crisis has passed, how are staff coping?
Yeah, it's interesting. I would say that in my conversations with people, I I think there was definitely a fatigue. And I think when I last spoke with you, we talked about that fatigue people were feeling. This is about a couple of weeks ago, I would say. So beginning of May.
Yeah.
I think that, it's hard to read everyone's mind, but I've not experienced that or seen that as much this past week. So I don't know if that means that some people have managed to have some downtime and are feeling slightly less fatigue. And also the fear of the unknown has gone away because this has all become the new normal. And so that may have played a role. People are being encouraged to take time off, whether that's through their own annual leave or not, but to definitely switch off when they leave work. So it's and also there's been attention to detail about mental well-being and lots of counselling services available, mentorship. So it might be a combination of all of these things, allowing people to relax slightly more than they were before. And again, a few people have told me that it's only now that they realise how stressed they were 4 weeks ago, because they can sort of now look back at it rather than sort of being in the space. And I would say that there's probably a bit more reflection going on now over what's happened in the last couple of months. So some of the conversations I've been having with people is, it can be pragmatic, transactional, or, what could we have done better? What should we have done? What went well? That kind of reflection, but also reflection about their personal well-being and what they have missed, what they want to do going forward. One thing I've been really struck by is that, as you know, a lot of staff in the NHS are from a BAME background, Black, Asian, ethnic minority backgrounds. And I think something like 1 in 5 of the NHS workforce, 2 in 5 of the medical workforce. And I was chatting to one doctor in training yesterday who's from Southeast Asia. And, he's not seen his family since December, and they'd planned to meet in March. And then obviously that got kiboshed because of COVID. And the country he's from has also got a 2-week quarantine rule. So it becomes impractical for him to go there and then to come back here because he'd spend 4 weeks in quarantine. So that human side of some of our staff and their inability to see their families is really hard. And and that's not just sort of outside of Europe. Even lots of our staff who have got family within Europe, who've got elderly parents who live in other European countries, for instance. It's something that, is we should all be aware of, that lots of our colleagues and friends just will, even though lockdown has eased a little bit and things seem a bit better, for them, a lot of them still cannot see family and friends, including, partners and children, because they're in other countries, other continents, which I think is difficult. The other reflection that I've noticed, and having discussed it with a couple of people, some of our nurses who came to work in the intensive care unit were from other areas of the hospital. And they've reflected that actually, although they were terrified when they first came, with support, they've become, less terrified and have actually enjoyed the fact that they've entirely changed their roles. And some of them are now thinking of making other switches. So, some of them had said to me that they were in a rut before with some of their other things they were doing, and they'd been thinking about moving, but they'd never gotten round to it. And this has been a real spur for them to change and move on. And I think that with the NHS, we need to retain our workforce. This is in pre-COVID, and one of the ways we can do that is keep people interested. And so one of the positive unintended consequences of COVID might be that it renews people's confidence that they can do something different, and that they go for it, and that will actually retain them in the NHS rather than them getting bored and leaving the NHS altogether. So I think hopefully that might be a positive
definitely
thing.
So what do you foresee for the next few weeks now that things are beginning to even out? How is work going to be for you and for the NHS?
Yeah, so my sort of from where I am, I think we've gotten to a new steady state whereby we are trying to reintroduce some of our elective work, be it outpatient or surgical, or other procedures. It will be at a reduced volume compared to pre-COVID levels. It will slowly expand, but the limitations will be on physical space because of the social distancing requirements and because of the not knowing whether somebody's COVID status. So I think more elective activity, but at a lower rate, volume than we have previously. And also we have to be flexible for any potential for a second spike.
Thank you for your insights today, Sanjay. It's been interesting as usual, and look forward to speaking to you again in the future.
Okay, thanks ever so much, Sarah. Take care.
All of the HFMA's COVID-19 related briefings, blogs and news articles are openly available on our website, hfma.org.uk. There is no need to be a member to access these, so please tell your colleagues. We have also launched a forum where finance colleagues from across the NHS can discuss issues and challenges in a safe space. You can sign up via the link in the network section on our website. If there are particular topics that you would like future podcasts to cover, then please get in touch via our email address, policy@hfma.org.uk. Thank you for listening to HFMA Talk. Don't forget to subscribe to this podcast to keep up to date with new episodes.